Well, hello everyone on the WebEx and everyone here. I hope everyone's having a beautiful Wednesday. It's gorgeous outside. But what's more important, it's gorgeous outside because of these individuals that are here. And why are they here? To talk about not only what we did during the pandemic, but what were some of the lessons learned, and making sure that we keep those lessons up in front and centered. Because without learning those lessons, sadly, we could get in trouble again. Sadly, we could have another pandemic or another outbreak, so things that we've seen before. But more importantly, these lessons learned are going to make sure that everyone here and in our community stays nice and healthy. But more importantly, it gets us prepared. Prepared for the unknown, and also more importantly, it gets the team prepared. It gets amazing leaders to be ready. And I'm so excited to have these amazing, just FYI, women. I'm saying women did save the city. I don't know. Let's not tell the mayor that. But more importantly, these amazing leaders not only wrote an amazing book, but also something that documented the hard work that we all did together. And also getting us ready for the future is always a good thing. You know, history is only good if we learn from it. And not only is this a testimony of the work that happened during the pandemic, but also what's going to set us apart from the future of those hospitals and health systems that were successful. Thank you so much for coming to Elmhurst. Thank you for being here and sharing your lessons with us. And we look forward to an amazing discussion.
Yeah, absolutely. Helen, thank you so much for those kind words, and it's great to be here at Elmhurst Hospital. So it's my pleasure to introduce Nikki. She is the Chief of Staff and the Deputy Director in one of the newest and most amazing offices in the White House, and it's the Office of the Pandemic Preparedness and Response Policy. And Nikki's going to talk a little bit more about the priorities and what is OPPR and how it fits into this very large public health, infrastructure that we have here in the United States. I'll first hand it over to Dr. Iavicoli to introduce herself as well.
Thank you so much. Thank you. Yes, I'm Laura Iavicoli. I am the Chief Medical Officer here at Elmhurst Hospital. I'm an emergency medicine physician, a professor at Mount Sinai School of Medicine at Mount Sinai. I've been here at Elmhurst for now, embarrassingly, or with pride, 26 years. So yeah, it's been a few decades. This is my family. I've spent more time with all of you than I do with my own family. So proud to be here, and proud to be here with Nikki and Dr. Madad, Dr. Romanik and Dr. Madad. And I'm going to pass it off to Syra to introduce yourself.
Perfect. Thank you. Yep. Syra Madad, Chief Biopreparedness Officer for Health and Hospitals. So I'm going to jump right into the meat and potatoes here. You know, we live in the age of outbreaks and pandemics, and you don't have to look any further than what's happening today around the world with the Marburg outbreak in Rwanda, which is kind of a sister of Ebola. You see mpox kind of continuing to spread throughout the world, not just the classic mpox that we were used to seeing a couple of years ago that kind of spread to many countries, but now there's a kind of a newer strain, if you will, of mpox that's been expanding, particularly in the DRC and neighboring countries. And I think Germany just had their first reported clade 1 case recently. And then there's so many other things that are happening, right? So there's no shortage of these different outbreaks happening around the world. And so when we talk about preparedness, it's never been more important. And I'd love for you to start off by sharing, first, what is OPPR? And since it is a new office, how was it created and what the role is? And then also just, I think understanding in the United States, our public health infrastructure is just so vast. So as we talk about bird flu or H5N1, the cows, the cattle that are unfortunately being infected in many of these states, they are overseen by USDA. The milk is being overseen by FDA. Any human cases are being overseen by CDC. So there's so many different institutions with so many different scopes, but they all function here in the United States. And so we'll love to hear how kind of OPPR fits into this public health landscape and what your top priorities are.
All right. So my name is Nikki Romanik, and I am the Chief of Staff and Deputy Director at OPPR. I have had the privilege of being there since day one. Our anniversary was August 7th, so we are, over being a baby. We're in our whiny years, if you if you associate with the kid. So why OPPR? OPPR, which is the Office of Pandemic Preparedness and Response Policy, which is a very long title, so we just go with OPPR from now on. OPPR was created based on the way that things used to work, and I think COVID really highlighted that it wasn't working anymore, to be honest with you. So what used to happen when there was a response that crossed all sectors in the federal government, whether it was an outbreak or a pandemic, usually it was an outbreak in our lifetime, is we would bring in a coordinator at the White House. There's been lots of different coordinators. Ron Klain was the Ebola czar back 10 years ago. We had a couple of coordinators during COVID. For mpox, we had coordinators as well. So OPPR is the office that is permanent, and it was congressionally mandated so. So instead of doing the coordinator bit a bit, we will forever be there. So we'll be there before the outbreak to do preparedness instead of just jumping into the outbreak, which is a key lesson learned, by the way. You need to prepare during peacetime before you get into crazy town time. So that's part of what our office is very focused on. When I think of kind of what are we trying to accomplish and what have we done so far, our overarching goal is coordination. Everybody says coordination, though. So what does that mean? Why are we all of a sudden the coordinating body for pandemics and outbreaks? Well, there are a lot of different federal government departments and a lot of different federal agencies, many, and all of them actually have different missions. And in a case like H5N1 specifically, we know, of course, that HHS is involved in USDA and FDA and CDC, and it is an alphabet list of different federal agencies. And we also know that each state is heavily involved in what's happening in each one of their states the moment that either birds or cows are unfortunately getting H5N1. So our job is to coordinate all of those folks and try and find a middle ground where we are all rowing in the same direction. So when I think what our goals were, our priorities, I think two buckets. I think short term and I think long term. Short-term buckets, responses, they have to be. They're acute. So right now we are the domestic lead for mpox. That's me. Marburg, that's me again. H5N1, retired Major General Paul Friedrichs, who is on a flight right now, headed this way. He is leading H5N1. And we coordinate with our global counterparts at the White House. That's the short term, right? We hope it's short term. And then respiratory season. Respiratory season happens every year. And every year people that absolutely do not need to die. And so we have decided to take a look at respiratory season and see where the gaps are and see what we can do to make this season and tweak it just a little bit better than it was last time. I think a lot of times when people think of COVID, they just think of COVID by itself. Respiratory season was there before COVID. We always had RSV, we always had flu, and now we just also have COVID. I think in a lot of ways, if you think about it, and this is a tweaky, different way to think, if you think about it, COVID actually elevated respiratory season. Not in the way we wanted it to, but we now have tools for RSV. We always have had the tool for flu, get your flu shot. And we have, obviously, the COVID vaccine. But we now have RSV vaccines. Our office has been very focused in working on getting those RSV vaccines into babies and also into pregnant mamas. It's an incredible vaccine. It's groundbreaking. It has been around as long as our office has really been around. This is the second year for it. So that's kind of what we are trying to do with that bucket. Now let's go over to the harder bucket, I think. I think it's harder because it's longer term goals. Longer term goals, what do we want? Preparedness. Nobody right now wants to prepare. That's what I'm learning. And it is the hardest part, I think, of our job is not the active response part, but actually the preparedness part. Or at least that's how I am seeing, like what I am seeing. And that's why I put preparedness in the long-term bucket, not the short-term bucket. Also trust. Unfortunately, public health has eroded trust to such a degree that all of these magical tools, medical countermeasures, vaccines that exist, you can have the most perfect vaccine in the entire world, but if you do not have somebody on the other side that's going to trust you to give it to them to make them better, it's useless. So that's a long-term goal of ours, and it's going to take a very long time, and we can talk a little bit more about that later. And then looking at all of our investments. What is the federal government investing in when it comes to diagnostics, treatments, vaccines, innovative treatments such as monoclonals? What are we thinking about when we're thinking of what kind of vaccine platforms or treatment platforms should exist in the United States? And who's investing within the federal government? And are those investments enough? And is the investment profile balanced? And are there gaps in that investment profile? Then we think about private sector. What gaps do we have in the federal portfolio when it comes to all those things I just mentioned? And how can we align with private sector? And how can private sector align with us as well so that we can work together to be more prepared? So that's a little bit about OPPR and what we are trying to accomplish.
Amazing, like incredible. I do have a question for you about the mpox response and OPPR's significant coordination that they did during the response. What were some of the key lessons learned during that response, and the U.S., how did it change the U.S. approach to outbreaks after that?
So I was intimately involved in the mpox response. Most of you probably don't know that I was, because I was the quiet one hiding behind two wonderful gentlemen. I was the third team member. There was a coordinator and a deputy coordinator and me that were all pulled into the White House for the mpox response. It actually preceded OPPR. That response was folded into OPPR after it ended. And now, of course, I'll get to the response we're doing now. But during the 2022 outbreak that ended up being absolutely horrific, I was actually in Geneva at the time, living there, and was pulled back to be a part of the White House response because we just weren't reaching people the right way, and the communication was not working. And, you know, nothing was going well, I will just say. People were exhausted from COVID, exhausted, beyond exhausted, and burned out from COVID. And mpox was not ever supposed to be here. It's just not something that we expected would happen. We also never expected mpox to affect a different population and transmit differently than it ever had before. It's a sneaky little virus, that one. So what did we learn? Well, during COVID, we learned that as much as we tried to put equity first, it was very challenging because everybody was panicking. And equity was woven into many different parts of the COVID response, but it was not at the top. You know, when you see those response charts, it was not at the top. For mpox, and I was a week late, by the way, because I was leaving another country and coming here. When I arrived, I looked at our org chart. Equity is at number 1. Equity was woven into every single line of effort that we had from day one. I think every single response should have that. I think that we should put those that are vulnerable at our forefront of our mind when we are planning and operationalizing any part of any emergency response. Another lesson learned. We came into a response with a large amount of people that just didn't have trust or faith. A lot of advocacy groups were very upset and angry that we had all of these medical countermeasures, but they were in Denmark. And we had these tests, but nobody knew how to order them for their patients, which I'm sure some of you probably experienced. And we had investigational medication, but doctors would have to take 7 hours to fill out 15,000 pages of paperwork. So all of those things kind of bubbled up quickly, and I'm glad it was quickly because it saved a lot of lives that it bubbled up so fast. All those things kind of converged, and we realized that, we needed to talk to this community, and we needed to talk to them often, as much as possible. The advocacy community, I would say there were 3 of us on the team. Number 4 was the advocacy community. They started off not being the biggest fans of us, and they were very, very nervous to, I think, work with us. But when we sat down with everyone and said, well, we're not going to tell you what to do, we need you to tell us what we're not doing. We need to hear what's happening on the ground. We need to hear, what are your challenges? What are your barriers? How can we help? What can we not help on? And I think that started, it was the beginning of a beautiful relationship, as they say. Those advocates and pharmacy advocates, and every advocate you can imagine, everybody calls it stakeholder engagement. But really, truly, what it was we were getting to know the advocates, and we were slowly and very, very slowly building their trust. So much so that after they told us these horrible things about how they were stigmatized because of where the vaccine was put in their arms, they were stigmatized because they did not like the word monkeypox, and they did not want to be associated with anything that was a monkeypox. They were stigmatized because it's a highly stigmatized community. People living with HIV was by far the highest risk community of any community during that response. So they were stigmatized to go into a CVS. They didn't want to go there to get a vaccine. They wanted to go to where they were comfortable. So we took all of that information, and we slowly started to tick away all the fears. We figured out different parts of the body where you can actually give the vaccine so that you don't have a mark on your arm that's visible. We worked very closely with our wonderful partners at WHO, and very, very much support their name change to mpox. We worked to get vaccine in the places that they suggested, like sex clubs and pop-up clinics and pride events. And we focused it more around a person's entire health. So it was more of a systemic approach versus just an mpox clinic. They could go there, they could get substance abuse education, they could get their mpox vaccine. At one point, they could also get their COVID vaccine when we timed that right. They could get HIV testing, so many other things. So I think we learned that you need to build it in within each community, and you need to learn from each community. And every community is not the same. So when we started seeing clusters, after everybody thought that this thing was over, the people who asked us if they could help were those advocates. They became our trusted messengers. They actually offered to help communicate in their communities about getting second shots or getting first shots. They put up pop-up clinics themselves for their communities. They became the fourth seat. So I would say not just stakeholder engagement, but look at who your stakeholders are in every response. Every playbook is always different. And make sure that you are hearing from them about what's happening. Because it's really easy to get in the federal government and think you know what's going on, but once you actually talk to people who are on the ground, it's a whole different story. So those are 2 big, huge lessons I learned from mpox.
It's a very powerful story. Sorry, I think the mic is not working, but no worries. Oh, thank you. Oh. 1, 2, 3. Oh, just went on. Thank you. That was a very powerful story, and I think mpox is a great example of how health equity was woven in. And as you've mentioned, equity should always be in the beginning, in the middle, and at the end. I think as we talk about different themes that I'm hearing kind of throughout many of your responses, as we all know, events are all local, and you're supporting at the local level with these community messengers and the like. And here at Elmhurst Hospital, what's really unique is that we talk about the COVID-19 pandemic. This was the epicenter of the epicenter across the United States, and it kind of all started from here. And Laura can attest to, I think, some of the challenges that were faced. They wanted me to shut up. But Laura, I think I'd love to hear from you of, as Nikki highlighted, the importance of trusted messengers and equity. If you can also highlight how during the Elmhurst Hospital's COVID response, how health disparities were illuminated during that response, and then any lessons learned that you also carried over from mpox and supporting that mpox response here locally.
Yeah, I mean, as we all know, as Dr. Madad mentioned, Elmhurst was the epicenter of the epicenter, and all of you who were here at the time stood up that response and ran into the fire and really helped save so many lives, countless lives. What we noticed was that the facilities at health and hospitals are in the most densely populated areas and some of the most uninsured and underinsured areas. Elmhurst itself is particularly, near two airports. We are the most ethnically diverse zip code in the United States, with 150 plus languages spoken within our zip code, languages and dialects. And I think the biggest lesson learned, as I was here at Elmhurst and then worked at central office in emergency management with coordinating the response for the health system, is that you really need to have access to supplies. And I think during such a pandemic response, you have to have an ability to break the glass and be able to share data and share supplies. So I think the biggest lesson learned, and we're still trying to figure it out, is how does that happen? We figured it out for the health system. And we kind of built the plane while we were flying it for the health system. So our incredible DNA, data and analytics team built incredible dashboards to be able to share data and see what was going on within the 11 acute care facilities, the 5 post-acutes, and understand, who was being strained the most and where we had room to either move patients, move supplies. So it's all about space, staff, and stuff. I think we're still working on that in terms of doing that with other health systems. And it doesn't need to be in blue skies and in a normal day that we would, need to understand who has capacity and space, who has extra supplies, who has, things that are needed, more nurses. But in those break the glass instances, I think having some sort of coordinated command center in the region is going to be vitally important in the next big disaster, to be able to move either the patients to where there are beds, maybe it's downstate to upstate. We definitely took in patients in New York City Health and Hospitals from other health systems. We sent our nurses to other health systems. We gave supplies to other health systems. And I think that would be vitally important for some Switzerland entity to be able to do that, to be able to see where there is capacity, where there is ability to move either the patients themselves or the staff or the supplies in order to mitigate what happened here at Elmhurst. And we were really overrun. I mean, I think everybody saw on the news what was happening. It was like a light switch turned on. We were overrun with patients. The emergency department was standing room only. There were 40 patients on some sort of ventilator support when we usually would only have, you could count on one hand how many patients we would have on a ventilator. We had multiple rooms of patients on ventilators. Every patient was on life-saving oxygen. There were 250 patients in a 70-bedded emergency department. Everybody was admitted, and the lines outside around the block. So when that was happening, I think it's those instances when you need to be able to leverage not only what's in your health system, but also what's in nearby health systems, and then you got to start looking outside of the region. Once that region is saturated, then you got to start saying what's going on in neighboring regions. Are they seeing the same thing we are? How can we leverage what they can offer?
Oh, amazing. I mean, heroic work all around, and thank you, and to everyone here, obviously, for all the different responses that happen, both that happen, that we know of, and then those that obviously that happen behind the scenes where you're just squashing the fire. So a lot of heroic work. So going back to you, Nikki, you obviously mentioned, the work happening at the national level. We'll love to hear how OPPR collaborates both locally, but then also internationally. As we talk about infectious disease outbreaks, we know obviously that they start locally and then they start expanding regionally and then nationally and then, unfortunately internationally. So we'd love to hear how OPPR kind of collaborates from the local, regional to international. And you obviously have an amazing background at the World Health Organization, so you have a lot of experience coordinating all of that.
Yeah, so as people always say, outbreaks are not just domestically focused. So to have an office like OPPR that is domestically focused, well, it just wouldn't make a lot of sense if all we did was talk to anybody who lived only in America. It just wouldn't go very far. The bug would race out of here and we wouldn't be able to chase it. So because of that, yes, we absolutely do. We work with, we are not the only country that came up with a pandemic office after COVID. There are multiple countries, in fact, that have pandemic offices that they've started. So our office talks frequently and regularly to all, if not almost all, of those offices. There may be one that we don't know about, but we talk to a large number of them. And we've kind of been building up our offices together, which has been a really unique and kind of interesting experience to all be able to share what we're focusing on and what's working in their countries and what's working in our countries. In our country, that's been kind of one of the highlights, I would say, is being able to collaborate and partner. I call that peacetime partnership. But then also those exact same offices, because we've built those wonderful relationships, we also have these responses that are always going to be going on. We are in a place and in a time where we are just going to have multiple responses for the foreseeable future because of, different things that have occurred in the last 30 years. So we engage with our multilateral partners a good bit. And we reach out to all of the, pandemic offices across the country to find out what they're doing for mpox. How are they preparing their own countries for mpox? How are they preparing their countries in Africa that are surrounding Rwanda, just in case there's a case outside of Rwanda? How is the EU preparing in case they have to transport a patient from Rwanda? Similar to how would the United States handle it if we had to repatriate a patient that has Marburg from Rwanda, which we've done in the past before, during Ebola, of course. All of those things, they all touch different parts of the global community. We work very closely with WHO, both on preparedness and in response. And we work with them on, the pandemic accord. It's countless topics. So it's peacetime mixed with a little bit of action, is kind of how I look at it. And then locally, how do we reach people? Part of the blessing of this office is it has something people call convening power. And, well, because we've invited you to things. But the benefit of the convening power is we can bring people into rooms that probably would never all be in a room together and talk about things in peacetime that we should be doing before we're in a response. We can bring together different healthcare systems, and everybody loves to kind of come to the White House, most people do, at least, and talk about things that people really kind of don't want to talk about. It's the one way that we've been able to keep those conversations going and learn. We may not have an extensive lessons learned overview and overhaul in the federal government yet from COVID. But what we do have is our office is mandated to have a report to Congress. And that report to Congress will cover all of the gaps from COVID. It will be the closest document that exists to an overhaul look at what happened during COVID and the gaps that remain, and also the things that we learned from COVID that should continue. So working alongside our local partners we've learned a lot of those things. It's not going to be a report where only the federal government talks about itself, because nobody wants to read that report. It's going to be a report where all of these local hospitals, local health systems, county and state health departments, local community-based associations, NGOs, all get to talk about their lessons learned from COVID. So we've been trying to do that this entire time over the last year or so. The report's coming in the next 2 weeks, or 2 months, don't worry. I'll send all of you an email so you guys can read it, or it'll be posted nationally. But that pretty much sums up our communication. We communicate as much as we possibly can to as many different partners, just so they're aware that we're there, and we're there to help coordinate.
Is it on now? Okay, great. I think that is absolutely the biggest thing on everybody's mind who went through this COVID response. And I know, especially here at New York City Health and Hospitals, and how hard everybody was hit is, were the lessons learned, and have we made the changes that need to be made for the next time that this happens, because we all know it's when and not if. And segueing into that, I'm going to just ask Dr. Madad a question, because Dr. Madad, you're our Chief Biopreparedness Officer. You had an integral part in all of the waves of COVID, but particularly I remember being here many late nights, early mornings with you, helping to set up warm and cold zones, and donning and doffing tutorials, and figuring out what we were going to do with PPE and et cetera. What innovations in diagnostics and PPE excite you about future pandemic preparedness? Is there anything coming down the line that you know of for future pandemics?
I think we are living in the age of innovation, and obviously AI is like the big thing on everybody's mind, which is really helping not just as we talk about pandemic preparedness, but also outbreak response. And we're already kind of seeing that utilized in the field in kind of amazing, innovative ways that we would have never thought about. Just mapping out chains of transmission, who's the index case, and how many people are infected from that one index case, and how many individuals can we expect, in terms of different generations of this one chain of transmission. So it's very exciting, I think, in the era that we're living in, because there is so much innovation. But one thing that I'm most excited about is, and I'd also love to hear more, from Nikki, is, so I think CEPI, along with many other organizations, are doing an amazing job as it relates to medical countermeasures, particularly vaccines. And we need vaccines because we know they are life-saving interventions. And when we talk about the current outbreak of Marburg in Rwanda, this is the first time we're seeing the use of the experimental candidate Marburg vaccine in healthcare workers. And I'd love to see, obviously, more of that innovation happening. It's not just, obviously, about making sure we are detecting these cases and being able to care for these patients, but what do we have to offer them, right? What therapeutics, what medical countermeasures? And I think organizations like CEPI and others that are really stepping up and trying to have a library of different vaccine candidates for some of the worst known viruses and bacteria and fungi in the world is quite exciting, right? And these are the things that you necessarily don't hear, during peacetime, but you hear about them when we're in an outbreak, right? You're hearing about the Marburg candidate vaccine maybe for the first time because of the outbreak happening in Rwanda. But this, this was years in the making. So it's really exciting, I think, to hear that. And I'd love to hear, Nikki, from you, like what's exciting to you? What do you see kind of in the pipeline? You hear and you talk to so many different agencies. What are some exciting things that that you're looking forward to?
Yeah, I will just say, for the Marburg outbreak, I am blown away by what the federal government, along with their partners, was able to accomplish. I cannot believe still to this day that they got vaccines, investigational vaccines, and investigational therapeutics on the ground that fast. And it was a combination of what we've been talking about. It wasn't just the federal government, it was CEPI, and it was other partners, and it was multilateral organizations. I have never seen something move so fast. I don't know if I lead the domestic part, and then there's somebody who leads the global part. I don't know if we slept a lot during those first few weeks, but it was incredible to watch the action of ASPR and CDC and all of those incredible partners come together and take a little help from our CEPI friends, et cetera. What am I excited about? I'm excited about, I don't know that there has ever been a time where an office spent time looking at an R&D portfolio across the entire federal government to see all of the different things in the pipeline for every single bacteria, virus, fungi. I don't know that that's ever happened, and we are doing it. We've already done it for viruses. It's incredible to see what DOD is doing, and DARPA, and Department of Energy, some of these innovative things that they're working on, and what AI is doing when it comes to medical countermeasures, and where we're at with the 100-day mission. It's incredibly exciting. We're lucky enough to have a brilliant R&D director on our team, and when he opened up our eyes to everything that he just identified himself across the federal government before we reached out to every single department and agency and asked them to spend all this time putting all of their projects together. What came together is incredible. There are so many things that are in pipelines for so many of these viruses, not nearly enough. And unfortunately, there's probably not something in a pipeline for a novel something that we just don't even know is coming. But there's so many things in the pipeline for the top 20 most terrifying pathogens that it's incredible. And to name something and see all the different departments they're doing completely different activities is exciting. And then there are companies that are working on wonderful PPE that is significantly more durable and comfortable to wear. Like we've gotten to a space where people realize that we can have innovative PPE. That really excites me. It excites me for clinicians who have to wear this PPE nonstop so that they're less, uncomfortable. So there's a lot of exciting things, and I'm just happy that we're able to actually put it all together. It's going to take a long time to get everything all together, but that we're going to put it all together and that we're going to be able to show where we're at with everything and line up all the gaps.
That's incredible. So that's for treatment. How about for diagnostics? I know that the government had a lot, the test and treat program, we learned a lot from that. But we did note that, during wave one, I think the testing was the biggest barrier. We knew everybody had it, or at least assumed, this was what we were seeing, but we couldn't prove it. And I remember, contacting somebody probably a week or more after I had seen them in the ER, and I was talking to her on the phone, and, her whole family was sick at home. Everybody was really, really sick. And I said, 8 days later, well, you all have COVID because the test finally came back. So, yeah, is there any innovations around the diagnostics?
There are. I was also a wave one human who couldn't get a test. That was me. I was 5 waves, but my first wave was wave one, where I found out 2.5 weeks later that the fact that I couldn't smell anything was because I had COVID. So I completely understand. Diagnostics is a very, very, very special thing for me. It is my one thing that I care the most about of anything. I didn't know if you knew that or not, but it happens to be the thing I'm the most passionate about, because diagnostics can screw up a response from the moment that the response started. You need to be able to have eyes on what the heck is going on. And if you don't have the diagnostics, you're blind. You're flying blind. So what I would like to see, and I hope that we get to this place, is that we have rapid diagnostics immediately within 100 days of every single outbreak, and way less than 100 if my dream comes true. Not just PCR, but that we have rapid diagnostics, because rapid diagnostics, it'll allow you to have the large landscape of what's going on, but it'll also allow you to do something called test to treat, which, can I talk a little bit about test to treat? Okay. I should mention it specifically to this room because New York City was by far, the best test and treat program that this country had. I mean, I have never seen a program like what you guys did. And I'll tell you a fun little story about how test and treat became a big thing in COVID. It had to do with the State of the Union. But what you guys did in your program, you had a phone number. It was like 202 COVID-19 or something was the phone number. You had vans that would come to people to test them and then to get them the medication. I've never seen a model be so efficient as the first go round. It's like your pilot became your program. It was incredible. And many, many, many places tried to copy you. And some did pretty well, but nobody was you guys. And so you guys are really the model going forward when it comes to test to treat. And I hope you know that. I don't know if you do know that, but now you do. You guys are the model for that. You guys are the people, you're the example I use when I say that we need rapid diagnostics and we need them affordable and we need them everywhere for everyone. And this is the reason, because we can absolutely save somebody's life by getting them the drug as fast as possible, because we all know that you want Paxlovid the moment that you get diagnosed if you need it and you're at high risk. You don't want it 7 days later. So that's my soapbox about test and treat. Oh, and I'll tell you the State of the Union fun little quote. So the president, when he was doing his State of the Union, he mentioned, it was just a one-liner, and he said, yeah, and we're going to do test to treat programs starting in pharmacies next week. And then we got off the phone, and I was like, we're not, is that a program that we're launching and no one told me? At the time, I was the White House liaison for CDC. I just kind of looked around. My husband's like, I don't know, find out. And I called HHS and I asked, is this a program you guys are launching and you just didn't tell me? Or, you should tell me. And they were like, we're launching it tomorrow. And I was like, have you done anything? We're building it this week. So that is how it became a nationwide program over a week.
Yeah, and I can attest to what you're saying about, which was originally called Test and Trace, and then turned it a Test and Treat. But Dr. Long, obviously at the direction of Dr. Katz, our system CEO, and their whole team did the most incredible things that I've ever seen. They really, that is really what saved this city, got this pandemic, got this outbreak under control, and got the city back on its feet again. And talking about health equity, I think that is the key, because you need to get the testing and the treatment to these densely populated areas where you can't, infiltrate. So the pop-ups that they created first for testing and then for treating, the mobile vans, just every aspect of what they stood up was absolutely awe-inspiring and just amazing to watch them as they rolled it out piece by piece. But segueing into that, Dr. Madad, do you believe pandemic preparedness needs to be more integrated as we see the climate change, to have adaptions around changes in climate? We're seeing a lot more zoonotic diseases. How do you think for the future we're seeing this?
Oh, absolutely. I mean, climate change is here, and we're seeing the influence and ramifications of it. And I think very similarly to how I opened up, we don't have to look much further. You're seeing just locally here, we've seen increased positive mosquito pools of West Nile earlier this season than we've seen in previous years. You've seen more cases. You're seeing other vector-borne illnesses spreading, much more amplified in different geographical locations. And the new one on the block, and I feel like everybody butchers it because it sounds like a French dish, is ourapouche. which is something, another vector-borne illness that CDC released a health alert on. And that's all to say that climate change is absolutely influencing, the amplification of many different infectious diseases. And H5N1 is another great example, right? If you look at the migratory patterns of birds, you're seeing kind of the spread of H5N1, and particularly as how it started here in the United States a couple of years ago. So climate change is here. It's definitely influencing infectious disease spread, and it's amplifying, in areas that you've never seen it before, which is, really unfortunate. And I think I'm very fortunate within the program that I'm in that we actually have a climate health focus as well. And we actually have one of our climate health interns here in the audience with us today. And we also have a climate health specialist as part of our team that's actually looking into a lot of these different vector-borne illnesses and seeing what can we do from a preparedness and a response perspective, and kind of building that into, our overall emergency management approach. So really, really, important topic, and so much more that has to be done. So I'm glad that you highlighted that. I want to just mention to the audience here, we love to take some of your questions as well. So if you have a question that you want to ask Dr. Romanik, feel free to ask. But I'm going to ask one more question, and then we'll see for those in the audience, if you have anything, just feel free to raise your hand, and we'll see if we can bring a mic to you, or if you can just stand up and ask your question. And just if you want to go ahead and state your name and affiliation as well, that would be great. So just, looking ahead, I'd love to hear just any core lessons learned that you learned from, whether it's mpox, COVID, obviously Marburg right now still going strong, but I still think there's probably some good lessons learned from that. So any lessons learned that you can share with us from these different outbreak responses that you've been part of?
So I would say, beyond the lessons that I've already kind of mentioned, one of the other lessons that no one ever really talks about until we get a new novel special thing that arrives is funding. For mpox, there was not a budget line for mpox. Mpox didn't exist, and there wasn't a budget for it. So mostly when there is a response, everybody expects there's going to be a supplemental package from Congress. And that is usually the case. With mpox, it was not the case. So one of the lessons we learned is that we have to have a diversified, flexible funding mechanism that is not a supplemental package, so that we could keep some of the things that worked. Because for COVID specifically, and a little bit mpox, but really for COVID, all the programs that were created, the incredible RADx program and ICAT, and there's just an incredible amount of programming, that wastewater, all of these things that are just essential now to how we use early detection. Those programs, don't mind my cheap little play on words, they're being washed away. They are. What the big lesson that we have not learned is that the things that we benefited from because COVID happened, and the science that grew during COVID, most of it we will lose because the funding and the infrastructure was not built around it. It was all built on supplemental funding. Not everything, but many of the ones I just named, unless they get a budget line, they will slowly start to disappear, which is really concerning. And we need to build mechanisms around our budgets so that doesn't happen.
That's really sad.
Sorry to end on a sad note.
Yeah. That's the bus cycle of the federal government, right? We throw in money when there's a problem, then we take it away when we think there's no more problem. But actually, Laura, do you want to add in some lessons learned from COVID as well as we're talking about lessons learned generally?
Yeah, I think the biggest lesson, and kind of tying it in even to the climate discussion, is it is I think COVID really highlighted healthcare disparities and inequities. We had cracks in the system going into COVID that turned into massive, huge valleys during COVID. So the response that New York City Health and Hospitals stood up was such an incredible response, which is was the impetus for wanting to even, write the book that we mentioned in the beginning, because we wanted to highlight not only the incredible response and everything that everybody did at New York City Health and Hospitals to save all the lives, and to put it into history that this happened so that, it was memorialized, and also to pay homage to all of you and everybody who stood up this incredible, massive response. But I think investing in the public health system and the safety net system is so vitally important, and COVID could not have shown that any better. I mean, that is the biggest lesson that we learned, that there has to be investment in public health.
Yeah, absolutely. So we'll take a question from the audience. I know we're right at time, but we'll go to this gentleman right here.
OPPR achieved so much, now we learned. But the most impressive part is I'm very impressed about the name change. You changed it from monkeypox to mpox. I was curious who changed the name. It's such a big impact, just a name change. You removed all the stigma. It's much better for treatment, prevention, for all diagnosis. This is such a big achievement. It's very important. It's amazing. I have some personal experience. I'm an old guy. During the SARS, suddenly people call me Guangdong. They always call me Dr. Liu because it's easy, LIU. But suddenly they call me Guangdong because SARS came from Guangdong province. My first name is Guangdong. I feel a little uneasy. Suddenly they call me by first name Guangdong. So it's very important. And also, for us during the pandemic, we realized, we got all the support from the community. They donated the food, they donated the PPE, and many people approached us and they said, yes, we have to support you. If you are safe, we as community is safe. They donated a lot. Even I still remember a person, pizza owner, delivered 100 boxes of pizza every day to us. So also, it's one way, but also just the beginning of the pandemic, me and Dr. Massey, we went to Flushing, went to Chinese community, went to many communities to do education. So we should keep a good relationship with community. We can distribute information, we can get the support. It's very important. And the other part very important is, for healthcare security, we need oxygen, we need ventilators. It was amazing during the pandemic. The ED could have huge oxygen tanks, and 5 people, 10 people can sit around that big oxygen tank. I was joking, it's like a hookah bar, we all sit around that huge oxygen. Many patients could sit around that oxygen tank, It's amazing, we never run out of oxygen. It's amazing. The other part is the ventilator, before the pandemic, the whole country had around 10,000 the pizza box, we call the pizza box ventilators. And after pandemic, now we have like 120,000 ventilators in the national stockpile. So for us, for this hospital, to prepare for the next pandemic, we need, the more oxygen capacity and the more ventilator. The other part is the emotional first aid. Whenever there's a pandemic, we need emergency, we need emotional first aid. We have to educate the community. We have to provide, the H3 or 3H, for us. The other part is, we should have the frequent drill, also like a tabletop exercise, routinely. Before the pandemic, Bill Fassbender and me, we went to Mayor's Office of Emergency Management, OEM. We had lots of training, lots of tables, top exercise. Yeah, so if we can have a updated plan, we do drills, we do tabletop exercise, it will help. But thank you for changing the monkeypox to mpox. It's such an amazing change. Thank you.
I'll share a very, is this broken? No, it works, okay. I'll share a very private story, and we're on the internet, so it makes me nervous to share it. But that name change happened because I came from WHO, and it's probably, I'm most proud about it. It happened because I built some amazing relationships with some folks at WHO, and through perhaps WhatsApp, we would talk all of the time, nonstop, for like 4 months, nonstop. I would text every single day, are we closer, are we closer? And then he would text back and be like, MXD, and I'd be like, no, that's a gun, that's not gonna work. Like, we need a different name. We'd go back and forth. And then finally, right around Thanksgiving, when I was about to fly home to see my family, I got a notification that WHO and DG Tedros were about to announce that they were changing their name. And then my friend called me and said, it's because you were so annoying.
I love it. It's the best story I've heard, actually.
It's true.
It made a huge impact. That's great. Maybe we can take one more question, if that's okay, from the audience. If anyone else has another question that they like to pose.
I guess as much a comment as it is a question. You talked about trust at the beginning, which I agree with you is so important. And with all these innovations and all the new things that are coming up, how do you counter all the misinformation, disinformation that's out there? I mean, we can expect that. We know it's going to happen. Is that part of your sort of mandate or your way of thinking?
Yes, it is. So that's in the longer term bucket, not the short term bucket. The reason I put it in that long term bucket is because it takes a second to erode the trust, but it'll take months to years to decades to build it back. And it's not going to be built back by one brush of one stroke from a paintbrush. It's going to be community by community. It's going to be a grassroots type approach, and it's going to be slow, unfortunately. What happened, it started eroding way before COVID, but COVID just highlighted how incredibly eroded the trust was in public health. And unfortunately, of course, also in CDC. And in NIH, and all of the people who were getting up on the microphone, unfortunately, became enemies to some people in some people's eyes, which is something we've never seen before in public health. Not on that scale, I would say. We've never seen it. In order to build it back, is going to have to be, many people in different communities trust different people. Largely, people actually still do trust doctors. I know. We've been talking to a lot of different folks outside the government to try and learn and wrap our heads around it about how we can actually not keep learning about the mis and distrust, but actually, take action to try and fix it. We have learned that largely doctors are still trusted in most communities, which is a relief, and many nurses as well. They kind of compete a bit for trust. But then other communities, they trust their religious leaders. They trust their community-based organizations that helped them during COVID. They trust, the people in their own community before they trust anything on TV, which is why I think it'll have to be community by community. It'll have to be communicating, not just in response, risk communication. Everybody knows risk communication, what you're supposed to do. You communicate what you know, what you don't know at this time, what you're doing to work on what you don't know, communicate transparently, communicate often. That's risk communication. But we have to actually do all of it and communicate all the different things of public health and what public health does besides responses. So it's going to take a long time.
Absolutely. We're in it for the long haul. I'm going to hand it over to Dr. Iavicoli to close us out. This was a really rich and fruitful discussion. So, Dr. Iavicoli, over to you.
Yeah, I just want to thank Dr. Romanik, Dr. Madad for being here. I'm so honored to be sitting up here with both of you, all of the incredible work that you have done. I mean, you've just probably touched the tip of the iceberg, and really looking forward to digging in and reading all that you have done and seeing all that you're going to do in the future. And same for you, Dr. Madad, equally. And thank you all for coming. We so appreciate everybody being here. We are so blessed here at Elmhurst to work with all of you and everybody in the health system. I mean, you know, this is the most magical place on earth to work, as I always say. So thanks to everybody for being so amazing.